Hi everyone, welcome to another episode of the Fits on the Go. And my name is Mustafa. I'm a clinical academic cardiology fellow from Keele University in the UK. Today I'm very delighted to be joined by Professor Hahn, Chief Investigator of the Smart Decision Trial, just presented as a late-breaking clinical trial this morning here at ACC and published in the New England Journal of Medicine. Professor Hahn, congratulations once again.
Thank
and
you.
thank you for joining us. For viewers, just to start with a more generic question, could you briefly summarize the key question behind smart decision and what gap in evidence you were trying to fill or address?
Yeah, beta blockers are a cornerstone therapy in patients with LV systolic dysfunction or heart failure. But recent randomized evidence suggests little benefit. The routine initiation of beta blockers in the early period after MI in patients without LV systolic dysfunction or heart failure. In contemporary practice, many stable post-MI patients are receiving beta blockers for years solely because of prior MI with limited evidence and potential adverse effects and medication burden.
That's a very interesting point. I think we have seen several studies over the last few years questioning the role of beta blockers in this population of patients post-acute MI without any significant LV dysfunction or heart failure. And the interesting thing about your study, I think the majority of the other studies were looking whether to start or not to start a beta blocker in the acute phase. But you looked at the discontinuation of beta blockers. How is your study different from the other study which looked also into the same principle of discontinuation, the ABYSS trial?
Yeah. To date, the ABYSS trial was the only randomized trial to directly compare discontinuation with the continuation of long-term beta blocker therapy after MI, but it did not meet the pre-specified non-inferiority criteria. So that's why we conducted the smart decision trial.
And we will come to this in a minute or so. But now, could you walk us through the key elements of your trial design?
Yeah. The inclusion criteria were as follows. We included the patients who have been on beta blockers for at least 1 year after acute MI and were MACE-free after MI but before randomization. And we excluded the patients with the LV systolic dysfunction or heart failure and ongoing heart failure treatment, contraindication to beta blockers, and atrial fibrillation. And the primary endpoint of our study was accomplished of all-cause deaths, recurrent MI, and hospitalization for heart failure. So
I think this is one of the key unique endpoints about your study when we compare it to the ABYSS trial, where they picked up hospitalization due to any cardiac symptoms. What was the reasoning or rationale behind picking up the hospitalization for heart failure endpoint?
Yeah, hospitalization due to cardiovascular reasons, including angina, or might be less suitable for open label design and more susceptible to clinical decision making compared with death, MI, as well as hospitalization for heart failure. So that's why we selected the hospitalization for heart failure instead of hospitalization due to cardiovascular reasons.
Yeah, which is fair enough. I agree with you totally. One more question is, which is also equally important aspect of the study design, because it's non-inferiority trial. How did you choose the non-inferiority margin?
It's always a very difficult question for a non-inferiority trial. But when we look into the previous non-inferiority trials in the cardiovascular field, the typical non-inferiority margin of a hazard ratio was between 1.3 and 1.4. So that's why we select the hazard ratio of 1.4.
And that's for relative non-inferiority margins. How about why did you go for relative non-inferiority margin rather than absolute non-inferiority margins, like what they did in the ABIS trial?
Yeah, when we chose when you choose the absolute relative margin, if the event rate is low, the non-inferiority margin is relatively so large compared with the event rate. So that's why we chose relative margin hazard ratio instead of absolute event rate.
And do you think the conclusion which was made about non-inferiority in this trial would be different if more strict or stricter margin was picked up?
But in our trial, the upper bound of 95% confidence interval was only 1.13. Okay. So even if we chose the smaller or narrower non-inferiority margin, probably the pre-specified non-inferiority margin would be bad.
Yeah. What were the key findings? So now we're coming to the main findings of the study.
During median follow-up of 3.1 years, the cumulative incidence of the primary endpoint was 9.0% in the continuation group and 7.2% in the discontinuation group, and the hazard ratio was 0.8, and which met the pre-specified non-inferiority margin. And there is no significant difference in the secondary endpoints, including the individual components of the primary endpoint and cardiovascular death, admission due to cardiovascular reason, and stroke.
And now these findings are coming just in contrast with the prior ABIS trial. So we are revisiting the ABIS trial a lot in this interview, but it's important to triangulate and contextualize the results. So how clinicians should approach the findings now?
I would like to point out there are some substantial difference in the ABIS trial and our SMART decision trial. The first, the primary endpoint was different, and the second, background secondary prevention appeared to be more intensive in the SMART decision trial than in the ABIS trial. And lastly, the interval from the index MI to the randomization was longer in the SMART decision trial than in the ABIS trial. So
that's very reasonable, I think, to mention, and fair enough. Now, we know the SMART decision was conducted in South Korea in the realities of one healthcare system. How should we think about the generalizability of your findings? Do we need more trials?
As you mentioned, one of the limitations of our study was that all patients were included in Korea. So I think the conclusion cannot be applied to healthcare system with different patient characteristics, revascularization strategy, or patterns of background medical therapy.
Yes, yes. Thank you for mentioning that. And my next question to you is, where do you see the field going next? Are we expecting trials to come up looking at earlier discontinuation of beta blockers or more personalized approaches to long-term therapy in this population?
Practically, it is difficult for us to have another big trial regarding beta blockers. So we are currently conducting IPD meta-analysis, combining data from ABIS and SMART decision.
We will be very looking forward to seeing the results of that meta-analysis, of course. And my final question to you, as newer therapies now emerging, including the cardiometabolic agents, the anti-obesity jabs. Do you think we are moving towards a future where traditional therapies and cheap therapies like beta blockers become more selectively used and we forget about them?
Uh, uh, Please remind the beta blockers are very essential medication in patients with heart failure or LV systolic dysfunction. But in my opinion, the discontinuation of beta blockers beyond the first year after MI would be a reasonable strategy in selected stable post-MI patients without LV systolic dysfunction or heart failure.
Professor Hahn, thank you again for your time and this important and thought-provoking study. And thank you all for watching. Stay tuned for more insights from ACC and from Fits on the Go channel on YouTube. Thank you very much.
Thank you.